Welcome to the first day of Weight Stigma Awareness Week 2023. I am extremely thrilled that those of you who have had the time this morning are here. I want to ask that everybody connect with one another. Feel free to connect on the webinar chat, via social media, anything. This week is really about you and it's about community. So I encourage everyone to connect, find people that you can align with, that are there for support and so forth. And we'll be talking more about that. Back in 2011, Wendy and I and the rest of the Binge Eating Disorder Association board thought that it would be a really great idea if we started challenging weight stigma, because we were seeing an awful lot of it in the eating disorders community and felt that that was really inhibiting the ability of people to get care and find recovery. So that's where this all started. And as many of you know, BETA merged with the National Eating Disorders Association in 2018, and I have since gone on to found the Body Equity Alliance. So feel free to check out my work there, and I'll have contact information at the end of this presentation. Okay, so let's get started. Challenging weight stigma and discrimination on the journey to body liberation is what we're talking about today. So I like to share my frame, which is basically where I'm coming from. And I want you all to know that I am a politicized activist seeking dignity for all. And that really comes from my own recovery process. And I have a background in political science. I've always been a very political person. And I think that's really important. And I'll talk about why it's important in just a little bit. My eating disorder, the research in the community, and the actual community itself informs my views as well. I believe that humans can be trusted with food in their bodies. I believe in the reclamation of the word fat, and will also use larger-bodied. I refer to myself as fat, and I welcome other people to do so as well. I think it's just a descriptor, as do many people in the fat community, but it's always a good idea to check with people about how they want to be referred to. I experience weight stigma and discrimination and healthism on a continual basis. As a fat woman, I expect to experience it every day, and I do. I believe those experiences created trauma that are ongoing. I believe that weight stigma or anti-fat bias is a trauma. I believe that any clinician treating fat clients must be informed about the determinants of health and trauma, and we'll talk about that a little bit more. I believe the lived experience is essential to inform research and clinical interventions, and especially research. You've got to have lived experience folks involved in the team to know what is really going on in that community and to understand what needs to be looked at. I believe in a relational and intersectional way forward toward body liberation. And we'll talk a little bit more about that. I want to see shifts in our community in terms of research and culturally competent treatment. I think that's something that's very lacking in our community. So what is the definition of politics? And as I said, I have a political science background and I love all things politics. And I remember sitting in my very first political science class in college, and I had a wonderful person who was teaching the class, and he said, "Can anybody in this class tell me what the definition of politics is, or political?" And everyone just kind of looked around at one another, and he said, "It's who gets what, when, and how." And I thought to myself, that's so simple. You know, if someone had asked me this years before, I would not have known what to say. It's very, very simple. And so whenever you hear someone talk about politics, what they're talking about is who is getting what, when are they getting it, and how are they getting it. So when you think about yourself and what your needs are, those are all political. When you think about communities and what they need, that's all political. And that's what our political leaders are supposed to be focusing on a daily basis. So I want to give just a very brief history about my background, just so you know a little bit more of where I'm coming from. I grew up in what is a wonderful family with people I love. But as we know, the number one place where people are shamed about their bodies is in the family. And I have a mother who at that time was struggling with anorexia back in my childhood. And shame was used as a tool. My mom said to me over and over, you know, I don't want you to experience the same things I did as a fat kid. And I completely understand that because being fat in this society is dangerous. It's full of shame. It's not the society culture, the built environment is not there to fit us. And so there's a lot of shame around that. And parents don't want that for their children. There's there was a quest to fit in and be loved. I remember thinking all of the time that I just wanted to fit in and be liked and be loved. And that went on throughout my childhood. When I think about little Chevese and the work that I've done in therapy, I know that you know, that was a difficult time, and little Chevese was hurt. I've done a lot of work in therapy since then, and I've also looked at the rebel part of me, the the sometimes destructive rebel part. That's also really helpful. And that is the person that probably more of you know in this community is someone who speaks out and discusses the shame of being in a fat body and what anti-fat bias does to us, not just in our daily living, but also within the eating disorders community in terms of treatment and access to care and so forth. And that destructive rebel really came out because I had had enough. I was tired of being shamed. I was tired of thinking about myself as the other. And so I not only started speaking up for myself, but I also started to engage in some pretty harmful behaviors around my eating disorders and also substance abuse and so forth. So it was a rough, uh, you know, 2 decades until I finally got help. Um, and when I got that help, I discovered, with the help of some really great therapists, that there's another way, that there is a paradigm out there that doesn't have to be about shame. It doesn't have to be about weight loss, and it doesn't have to be about diet culture. That for me was all about healing, healing from my eating disorder, healing from the shame, healing from the trauma, and seeking dignity for myself and others. And so I went from this sort of destructive rebel to a constructive rebel. And again, that's probably the person some of you know. And that's when a really different kind of activist for me evolved and emerged, because I have always been interested in politics and social justice for people because I care about people and I believe there are great injustices in this world. But I finally figured out that there was injustice that I was incurring because I was being oppressed by the society who did not think that my fat body was okay. And I learned how to think about my body as being okay. So, what is the goal of body liberation? And this is from uh, Dahlia Kinsey, who created the Body Liberation for All podcast as a resource for QTBI POC folks who are ready to become the happiest versions of themselves. And it's a really, really great podcast, and I really, really recommend that everybody take a look. But in body liberation, I'm tripping over myself this morning. Body liberation is really about every body, and seeking to provide the knowledge and really the internal um, feeling that we are worthy, we can be healthy in whatever way you deem health, and desirable to others. And you'll see that theme throughout this week for Weight Stigma Awareness Week. We really wanted to show that there are all parts of, or many parts of the eating disorder and fat activist community, and that fat folks can be worthy, healthy, and desirable. And that's without changing their bodies. So why is body liberation necessary? And I've alluded to this. It's because of weight stigma and weight discrimination, which are examples of determinants of health, oppression, and healthism. And we're going to talk about each of those things. So what are determinants of health? And I think we hear a lot of this bantered around these days, and most people don't really understand what that is. But a determinant of health is a social and economic environment, the physical environment, the person's individual characteristics and behaviors, the context of people's lives determining their health. And so blaming individuals for having poor health or crediting them for having good health is really inappropriate for reasons that we'll talk about. And we know that individuals are unlikely to be able to directly control many of these determinants of health because of their income and social status, their education, the physical environment, social support networks, genetics, health services, and even gender. All of these things contribute to determinants of health. And so if you have a person who is along the spectrum of fat in what we may call as a super fat body, who does not have social support networks, who may not have an income, who may be queer, that's an example of determinants of health that may elude actual treatment for an eating disorder or access to care because of the lived environment not being built for someone, chairs that don't fit, blood pressure cuffs that don't fit. All of these things can lead to worse health rather than having built environments and the proper tools to help people no matter their size, their gender, their education, and so forth. So that's really, really important. Health equity is social justice in healthcare. So health disparities are health differences that adversely affect socially disadvantaged groups. And these categories reflect social advantage or disadvantage when they determine an individual or group's position in a social hierarchy. Health disparities do not generally or do not refer generically to all health differences. And in any case, they're likely to reinforce the disadvantage and vulnerability. So, as I said, these are things that we must address if we're going to equalize health in a healthcare setting, and that is a social justice issue. It's back to the political definition of who gets what. And again, I apologize for my tripping over my words a little bit. I didn't have time to go through this morning when we found out that Wendy couldn't do this. So I'm a little rusty at this particular talk. So forgive me. So let's talk about stigma and discrimination. Stigma really fuels discrimination. So if someone believes that someone is not worthy of, as we were talking about, the built environment working for them, if they think that they're not worthy of good health care, or that a person, a physician, for instance, doesn't want to touch them because they're fat or for some other reason. Um, that is stigma, and that stigma leads to the discrimination. So, if people are looked upon as other, they are not given the proper tools, they're not given what people need to live lives in an environment that works for them, then that stigma and discrimination come together to become oppression. And these aren't isolated incidences. They are the norm in healthcare and society. And I can say that, I live in a body that is what's considered probably medium fat. And I do not experience stigma, discrimination, and oppression nearly as someone who is in a body that is larger than mine. So I have some privilege around that. And yet, I still do experience it. There are all types of ways that we experience microaggressions and so forth in healthcare, and it really does nothing to serve people and what they need and what they need to get from healthcare. So, stigma, discrimination, and oppression are perpetrated by a complex system of power, and those are sustained by pervasive beliefs. That power is sustained by pervasive beliefs. So people who have power make the rules. And when those rules don't work for any one group, then that group suffers as a result. They further place the blame on the individual. So in this case, they're placing the blame on the body size and on the person and treating fatness unjustly with bias. So that bias, the stigma and discrimination, creates poor overall health. And we know that some of the same diseases, some of the same issues that fat people have that are blamed on higher weight bodies are also found in research to be associated with stress, which is a very common thing when you live in a larger body and you're trying to operate in a world that's not made for you and in fact wants to change you. And with the stigma itself. So I suggest, taking a look at those studies. We will have studies on the website this week at weightstigmaawarenessweek.com. And if you're giving a talk or if you're speaking with a client or with parents, you can provide that information to people so that they know it is a real thing. Another layer to this is healthism. And I'm going to read this because I think it's really important. Like medicine, healthism situates the problem of health and disease at the level of the individual. So it's putting blame directly on the individual. Solutions are formulated at that level as well. So that means that the solutions that we have to the perceived problem are situated with the person. And so, in other words, if you're fat, then you need to lose weight. So it's your responsibility to lose weight. To the extent that healthism shapes popular beliefs, we will continue to have a non-political and therefore ultimately ineffective conception and strategy of health promotion. Further, by elevating health to a super value, and what this means is that above all, health is the most important thing. And I think that I understand why we think that way. We all want to be quote unquote healthy. We want to live. We want to be with our families and our friends and so forth. But when we turn it into a super value, often that means we're doing more harm because we're not looking at the wider consequences of the culture and society, and instead we're just saying, you need to lose weight. All the responsibility is on you. A metaphor for all that is good in life. Healthism reinforces the privatization of the struggle for generalized well being. And again, it's all about the individual rather than society really looking with a more broad view at overall health of the population. So Kimberly Crenshaw is wonderful, and she is credited as being the person that, along with some others, who came up with intersectionality. And it's really, really important when we're looking at these ideas in social justice of privilege and oppression and determinants of health and so forth. So intersectionality is a lens through which you can see where power comes and collides, where it interlocks and intersects. It's not simply that there's a race problem here, a gender problem here, and a class or LGBTQ problem there. Many times that framework erases what happens to people who are subject to all of these things. So, I liken it to, in a more positive way, putting together a recipe. You're adding things into the pot to build something that you're then going to eat, and it's all of those pieces of the recipe that give you the flavor. In a not so helpful way, that's how intersectionality is. We look at where people's identities intersect. And so, you put into the pot, person's gender, their race, their body size, their sexual preferences, their gender, all of the things that make them up and make them into the human being that they are. And those intersections are things that we know in society are difficult on their own, but when they come together, it makes something even more difficult. Like a recipe may not be a great metaphor, but it's what I was thinking about. The recipe tastes a certain way because of the intersection of all of those spices and ingredients, whereas someone, as a person, they come together as that person because of all of their identities. And that also influences then how much they're oppressed, because if they're in if they're a member of groups that are oppressed, like those in black and brown folks, the LGBTQ community, and so forth, each of those intersections are going to build on who they are and what they have access to. And that is politics. That is who gets what, when, and where. And in the FACT community, as we've been talking about, the lived, our society, the built environment, and so forth, are not there to support us. And much like there are systems in place not to support other people with other identities. And when you bring those all together, that can really be much more difficult than somebody that may only have one or two of those identities or none. I have a lot of fortune in that I am white. I am not at the highest weight groups. I have educational privilege. I have marriage privilege. There's a lot of privilege that comes in being a heterosexual married couple, all kinds of things that give me privilege in those systems. So I hope that helps everyone understand who may not have an understanding of intersectionality to date. And all of this is costing us. I'm a partner with Dove's Size Freedom Campaign, which NAFA is leading, and NAFA is a really great group. You can find them on the website, weightstigmaawarenessweek.com. And Dove worked together with Striped, a incubator at Harvard, and put together this study. And what we know from the study, most of us knew this beforehand, that body dissatisfaction and appearance-based discrimination are indeed public health crises. And they are that because they are costing us individually and they're costing society. So $305 billion annually are spent due to body dissatisfaction. And there's all kinds of ways that that money can be spent. But when you think about weight loss alone, that is a huge amount of money that is spent every year. 501 billion annually due to appearance-based discrimination. And we can think about this as in terms of Black and brown folks wanting to be lighter skinned. There are all kinds of ways that appearance based discrimination plays out, but it is also a huge cost to society. So I'm thankful for Dove, Striped, and also Deloitte, who did this study and really showed us that this is a public health crisis. So what do we know about weight stigma and who is perpetrating it? And, this is a study that goes way back. And when we were preparing the first Weight Stigma Awareness Week in 2011, and I was really digging into the studies and I saw this, it was very interesting. And I talk about it at most talks when I am discussing weight stigma. But it's really interesting to know that the number one source of stigma is, in fact, family members. And I think we have to really understand that that is not something that we're blaming anyone for. I have stigmatized people in the past unknowingly. Family members want their loved ones to be well, they want them to be accepted and loved and liked in society. And so, there are these subtle things that people will say. In my family, I had a grandfather that once told me that I would never find a partner in life because I was fat, and if I didn't lose weight, that I'd be a lonely old maid. And as you can imagine, that was very, very hurtful. And so I think that there is a spectrum of how hurtful people can be, but I know it wasn't because he didn't love me. It was, in fact, because he did love me and he didn't want me to be alone. Doesn't make it right. Again, very, very hurtful. But these are the kind of things that happen. There's food monitoring. There's all kinds of things that go on. So family members are a place where we really have to focus in helping people understand why this is not helpful. The second place, I think that anyone who is higher weight, larger bodied will know and be very familiar with, unfortunately, and that's amongst doctors. And you can see that, in this slide, we've highlighted in red healthcare providers and where they are in the study in terms of how much stigma people incur from them. Doctors right up there after family members. And this is because they do learn in medical school that this is exactly what they're supposed to do, that not that they're supposed to shame, but they don't see it that way. They don't understand that coming into a doctor's office is in of itself very difficult for fat people, because they know that the first subject is going to be weight, and that the last subject is going to be weight, and that everything that they are there to be seen about is going to be blamed on weight. And so it's very dangerous. And we hope that doctors and other healthcare providers will be listening and learning that they have to do things in a different way, and that the goal is not weight loss. In the obesity, and I say that in air quotes because I'm not a fan of that community. There is a lot of focus on weight stigma now, as a means to help people to lose weight. They recognize that shaming people is not helpful. And so a new approach is to address weight stigma and to encourage people to lose weight in a more compassionate way. I will say that I believe in body autonomy, of course, that is number one. But I do think that physicians and other healthcare providers also have a duty to understand that weight loss may not be the best thing for someone, and in most cases is not, because of the ramifications of the pursuit of weight loss. And not to mention that it fuels more stigma in the greater society. So experiences of weight stigma do become PTSD for some people. We do know that a lifetime of experiencing weight stigma really does become a trauma. And so the body shame and so forth can very much lead to binge episodes, which may be objective or subjective, and that there's an overvaluation of weight and shape and eating concerns. So you can see that this really forms the foundation of what may become disordered eating or eating disorders for some people. If you're carrying around so much shame and you are constantly restricting, we know that that is then going to result in some binge eating, and may eventually result in binge eating disorder. Weight bias was cited as the fourth most common form of discrimination amongst U.S. adults. And in fact, the Harvard Implicit Bias Program reported last year, I believe, or the year before, that most of the biases that they look at, which are, racism and, sexual preference and all of the biases that we can think of in society, they all went down. Weight actually went up. So it's really important to consider that this is an area that we need to really focus on and think about when we're doing our social justice work as a whole. I think that the social justice community is only just beginning to realize that this is something that is also a piece of the intersectional puzzle. And for some people, it's going to be a big piece. So I digress, but I thought that was important to get in there. Over the past decade, the prevalence of weight bias has increased in the US by 66%, and implicit bias around weight has increased steadily over the last decades, while others have decreased. So that is the implicit bias project that Harvard is taking on. So as I mentioned, weight stigma does predict dieting behaviors, dietary restraint, bulimic behaviors, binge eating, unhealthy and extreme weight control. And, in that, I would just say weight control. Fasting, using diet pills and laxatives or diuretics, using food substitutes, and skipping meals. So that sounds like disordered eating to me. And as we know, disordered eating is just one step away from a full-blown eating disorder. Um, this is really important because, as I mentioned earlier, weight stigma is related to stress. And stress produces many negative behaviors, including binge eating, increased calorie consumption, all the things we just talked about on the last slide. It increases cortisol, C-reactive protein, which is an issue in heart disease at times, A1C, which obviously is diabetes, elevated blood pressure, and poor treatment. So with those combined, there will be times when people will actually they will gain weight when they have experienced weight stigma. And the outcomes are, as I said before, very similar to some of the health diseases that are typically blamed on higher weights. So, the physiological health outcomes, poor glycemic control, less effective chronic disease self-management, and more advanced and poorly controlled chronic disease. And then, of course, the psychological health and distress, depression, anxiety, low self-esteem, and so forth. There's an interesting study that talks about experiences of discrimination or stigma are being significantly predictive of PTSD symptoms 1 year later. So as I said, stigma is a stressor. There is increased and sustained anxiety as a result of being a target for ongoing discrimination, bullying, microaggressions, and lack of physical and mental care. These are what I call the microaggressions, the daily media images, stereotypes that are perpetrated, and the sense of self that really dissipates at the more that one is that one experiences weight stigma and anti-fat bias. Higher weight individuals themselves internalize and sometimes become the bully and perpetrator of stigma. Some of the worst experiences that I've had myself have been with other fat people who have internalized all of those messages, and they don't like themselves, they don't like their weight, they don't like some of the behaviors that are a result of the bullying and the weight stigma that they've incurred, and they become the bullier and the perpetrator. And that's really sad. I'll share a story also just with myself. I had, so much self-hatred around my own body as a child and in my teens that I was determined that I was going to shield myself from those things as best as I could. And I was going to be in a friend group where I was the only larger-bodied person. And that I would go along with them when they were making fun of other larger-bodied individuals. And it hurt inside, honestly. I knew what I was doing was wrong, but that was a way for me to be what the fat community deems a good fatty. It was a way for me to look good in the eyes of my friends and acquaintances, and be behaving in a way that they thought was appropriate. So I have some regret around that, but I also know that that was because my internal sense of self was so damaged. So trauma really is an outcome of oppression. And I don't know if any of you know the name Pablo Sandoval. Pablo was a Major League Baseball player who at some point announced or made public that he had binge eating disorder. And I believe he was with the Red Sox then, and as a Yankee fan, okay. But Pablo was a Red Sox player, and he was ultimately fired because of his disorder. And Pablo lost his career. He was shamed, I'm positive, by other players and by the team leadership. He, despite being an incredible athlete, had to leave his baseball career behind. And we know that the more co-occurring stigma and discrimination, the more the trauma is entrenched. So here's a person who was, may have had a history of being in a larger body, became an athlete, and has probably experienced discrimination along the way. Pablo is also a brown person, and so that's an intersection that makes things a bit more difficult, more oppressions to deal with. So that trauma is very real, and it can lead to the loss of careers, the loss of family, the loss of friends. There are all kinds of things that that oppression can affect. So we've been talking about oppression as a chronic stress. And, in the treatment community, this talk was not meant to be eating disorders specific, but in the eating disorders community, treatments are not adapted to the individual. So, if you have a white thin person who is seeking treatment for binge eating disorder, typically that person is going to receive treatment, but frankly, the treatment providers may not know what to do with that person because they think that, binge eating disorder is only a disorder in larger bodied persons. The reverse can be true as well. You could have a person in a larger body with anorexia who goes into treatment with a clinician who doesn't know what to do with that person. They may even prescribe weight loss. There's a lot of thought in the eating disorders community that, well, if we can get a person to stop engaging in their behaviors, then we can treat them with weight loss. And that is just not acceptable for those of us who have been through this and know how it works. So that can be another trauma. And I wanted to present this wheel of power to everyone so that you can look and see that, there are all kinds of different marginalizations and there are lots of different centers of power. And so looking at where those intersect can definitely be can be dependent, or the type of treatment that a person gets could be dependent on where they lie on that wheel of power, and what misconceptions the treatment community might have about people when they show up and what their positionality and intersections are. So that is something that I would love to see the eating disorders community take more seriously, to really look at a person's experience, look at where they where they're positioned in society, look at where they're marginalized, and think about what their needs, how their needs may be different from another person within the milieu, and even in an outpatient setting. It's really, really important. And this is why so many of us have been talking about social justice and weight stigma and other types of oppression, because it really, really, really does affect who gets what, when, and where. And it could be the difference between life and death for some people. So I just wanted to remind everyone, and I'm sorry, there we go. Okay, I needed to move something on my screen, but remind everyone again that body liberation is the freedom from social and political systems of oppression that designate certain bodies as more worthy, healthy, and desirable than others. So that's the goal, and I just wanted to remind everyone of that as we continue to go along here. I'm sorry, my computer is stuck. For a minute here. Okay. So, you know, a lot of people, I'll give these talks, and you know, people will say, well, that's great. How do we do body liberation? How do we integrate social justice into our work? And you know, body liberation and social justice are not types of therapy, obviously. They are not treatments, but they are something that can come into the room. They can come into the space and into the relationship between the person and the clinician. And it all is about that positionality and those marginalizations. That is what is there in the room showing up for the clinician. And if those things aren't addressed in terms of how they interact with an eating disorder or with disordered eating, or a person that is there because of depression and anxiety and so forth, and they're living in a larger body and, you know, incurring weight stigma and you know, oppression and so forth, then we're not doing justice. We're leaving out a big piece of the puzzle. So one of the things that is helpful is integrating health at every size. And this is across the spectrum of eating disorders. And I would argue even for people without eating disorders who are, you know, experiencing depression and anxiety and so forth. But health at every size helps us address weight-based social inequities through a weight-inclusive lens. And I'll talk about that in just a bit. A person who is stigmatized because of their weight possesses a weight that leads to a devalued social identity and is often ascribed stereotypes or other labels, which we've talked about. And this denotes a perceived deviance, which can lead to prejudice and discrimination. So that's what HAES, or Health at Every Size, is really about. And we are going to have a wonderful speaker on Thursday, I believe, Angel Austin from ASDA, which is the organization that oversees the HAES paradigm and is really, really helpful for many people. I suggest belonging to the organization. The principles, as I said, this talk was a surprise to me this morning. So I didn't get a chance to change this slide, and Angel will give us more of an update because I know that the principles have undergone some updating But I think what is really important is to understand that health at every size, and it's not health at any size, it's health at every size, is about weight inclusivity, and that's accepting and respecting the inherent diversity of body shapes and sizes and rejecting the idealization or pathology, can't talk today, pathology of specific weights. So sorry. It's health enhancement and it's eating for well-being. So those are things you would expect for anyone in whatever size body. And sorry again, my some reason my computer is not wanting to shift my slides. Okay. So how do we go forward from here? We have two choices, really. And I hate to be so black and white, but in this instance, it really is a black and white issue. And that is that we have the choice to either work in a weight normative way, and that is that healthcare providers and others will emphasize weight and weight loss and use that to define health and well-being. Or we can use a weight inclusive approach, which the emphasis is on viewing health and well-being as multifaceted while directing efforts toward improving health access and reducing weight stigma. So weight inclusivity, I'm very fortunate now to have a doctor who practices in that way. And what that means is I go into the office and I am not weighed. She listens to all of my concerns and notes them. We don't talk about weight loss. We don't talk about my body not being in, a specific BMI category. We talk about the issues at hand with my body that can be addressed. And so I do take some medications. I go for regular checkups. And a lot of the reason that I feel like I am healthy, both physically and mentally, is because I've gotten that weight inclusive care. I have a therapist and I have healthcare workers that are doctors and nurses and so forth who don't look at me and see my weight, or of course they do see my weight and I would want them to, but they don't see it in the way that they use it to address my health. And that is the important thing that we are interested in here. So health justice and health equity means that all bodies have an equal value. It doesn't matter what disability you may have. It doesn't matter the size of your body. It doesn't matter what color your skin is. It doesn't matter what your appearance is. What matters is that all bodies are equal, that we are giving to all bodies, what they need. And that is not the way, unfortunately, our society is set up right now. Bodies are seen on a hierarchy of health, and that lends itself to the healthism that we were talking about earlier, that certain bodies are conceived of as very healthy and therefore they are at the highest ranking. We have that in the eating disorders community where thin bodies with eating disorders are considered better than fat bodies with eating disorders. And no one says that in an outright manner, but we know it from the type of care that is given. We know that from the way that research is done. And so we know that our bodies, and when I say our bodies, I mean mine and others who are fat, are lower on the totem pole, and that includes the type of eating disorders we have as well. They are ranked, and that's something that we hope to change in this community because they're all difficult and deadly disorders. So I love this from Gloria Lucas, who runs Nalgona Positivity Pride. I suggest going to the Nalgona website and looking at what Gloria offers. She does a lot of really great training. But, you know, healing from oppression is one of the things that she talks about. And, you know, in what we're seeing here is that we really need to go from socialization of, you know, bullying and stigma and so forth, shame, to reclaiming who we are. And that's really about that inner self and being comfortable in who we are, and you know, with our marginalizations and our intersections, and saying, you know, we have rights, and that we deserve, you know, a piece of the pie just like everyone else. That there's unconditional acceptance, that there is connection, and that we're speaking up in a way that lets people know that, you know, these systems are not helpful to us and that we need to move on from them. So I will leave you with this. And there's a lot of debate about this in many communities. Are we going to fix the airplane while flying? Meaning, are we going to work on the inside of institutions and organizations and systems to change those systems? Or are we going to burn it all down? And I think that we can do some of both. There are some people who are a bit better at changing the system from within. And there are those who like to be and are very good at being on the outside and calling out what systems need to fall and what need to really just be rebuilt. What we don't want to do is focus on fixing people. People are a part of the system, they make up the system. So we don't want to make it about one person. We want to make it about the whole system. And that's why, for me, it really is about working within the system to change it. Because I do worry about, you know, crashing a system and then rebuilding it, and where people will fall while that happens. So I'll leave, for those of you who are clinicians, researchers, and so forth, I'll leave you with these suggestions. And that those are to consider the positionality of each of your clients. It's to become trauma informed. I think that's really, really important if you're going to work with people in larger bodies. As I've said several times throughout the talk, trauma is a part of the story. And so becoming trauma informed is really, really critical. Read and listen to the lived experience of those in different positions than you. So if you are a thin person, listen to the stories of larger bodied people and don't tell them what their story is. I think that's especially important in research. It's important to have people who have been through, whether it's eating disorders or anxiety, depression, whatever it is that you're looking at. People who have lived in larger bodies, have them work with you, hear their experiences, and understand that maybe some of the things you're doing in your research or in your clinic are really harmful to them. There are going to be people who are just not ready to share that, and who may still believe that losing weight is the way out of oppression, and that's what's going to work best for them, and that's okay. You know, but maybe listen to the people who have discovered that that's not truly the way out, because you can't just make oppression go away. It's still going to be there for others, and so that's why we say that we need to fix the system and not the person. Consider the wider lens of trauma, and that really is that, you know, beyond just some of the traumas we hear about regularly, that people's positions and their bodies can actually result in trauma that is all based in shame. Consider trauma from ongoing weight stigma and other oppressions, and I like to think of that as a chronic trauma, excuse me. And when you think about, I think about it in my own life as an arc. I started incurring weight stigma from a very, very young age, and the top was really when I was at the height of my eating disorder, and I was taking it all in. The weight stigma that was coming from individuals in the culture, I was taking all in, and I was trying to fix myself. And now that arc has gone down to closer to a sort of normative place where, not that I don't let it bother me, but I've made very clear boundaries in my life around what I will participate in and what I will listen to about my body and about other people's bodies. So that does protect me from some of the weight stigma and the oppression, but it's still there. It never completely goes away. Okay, so that is the conclusion of this talk. Thank you all for bearing with me. This this has been a difficult morning, trying to get everything up and running for the week, and also kind of switching gears and having to give a talk. And I apologize for stumbling all over myself. I just wasn't prepared to do this, but I hope that you got something to take away from this. And feel free to reach out to me. My website is on this last slide, as is my email address, and I am very happy to talk to anyone at any time. Send me an email and we'll set up a time to chat. And if you have any questions, I'm very happy to take those as well. Thank you, everyone.